Hey there, everybody, and welcome to this presentation on unique issues in the identification and treatment of addictions in older adults. I'm your host, Dr. Dawn-Elise Snipes. Today, we're going to explore the issues unique to the diagnosis and treatment of addiction in older adults, including medication interactions, reduced liver and kidney clearance, altered drug responses, diagnostic difficulties, and treatment challenges. We'll explore how substance misuse may impair the functioning of other prescribed medications and identify strategies to prevent and address addictive behaviors in older adults. So let's start out by talking about why older adults respond differently to medications. And we're going to talk about a lot of things today, but I want to start out by pointing out that what we're talking about is the cellular age of the body, not necessarily the chronological age. Body composition changes, nutrient deficiencies, drug interactions, white matter integrity in the brain, concurrent health conditions, and kidney and liver issues are relevant to all age groups. If you've got stuff going on in any of those areas, it may impact your response to various drugs. Chronic stress and substance misuse, and I don't know anybody who doesn't have one or both of those. Chronic stress and substance misuse accelerate biological aging, making the body physiologically older than the chronological age. So you may have a client who is 45, 50 years old, but they have been under a heap ton of stress for 20 years, and their body is responding more akin to that of a 60-year-old. As the body ages, drugs stay longer and increase in concentration. As the body ages, we tend to lose muscle and gain fat, whether we want to or not. One of the reasons that people are encouraged as they age to engage in strength training activities, etc., is to help keep that muscle mass. However, as we gain more fat, the fat-soluble drugs tend to be much more available in our body. For example, benzodiazepines, these are fat-soluble drugs. For diazepam specifically, and your benzos are your anti-anxiety medications. For diazepam specifically, the half-life increases about 1 hour for every year of age. So a 70-year-old adult might have a half-life of 70 hours. So it takes the drug 70 hours to get halfway out of the body, essentially. Whereas a 20-year-old, it only takes 20 hours. You can see how if you prescribe the same amount for a 20-year-old as a 70-year-old, it's going to build up in the 70-year-old's body really fast because they're not clearing it out. It's just sitting there. And that can rapidly develop into toxicity. Likewise, for people who self-medicate, we need to make sure that they're aware of the effects of aging on their body's response to medication. Not that we want to encourage them to self-medicate, but we know it happens. Water-soluble drugs, and those are your ACE inhibitors, or not your ACE inhibitors, I'm sorry, your NSAIDs and other drugs like that. With aging, total body water decreases while body fat increases. Water-soluble drugs distribute into less body water, making a stronger solution, so it sits in the body. Think about if you've ever made sugar water, maybe for hummingbirds or something. If you put a half a cup of sugar to a cup of water, you're going to get a good, strong solution. But if you put a cup of water to a cup of sugar, you're actually going to have a solution that's too strong and it can't hold all of the sugar. And that's what's happening when people take water-soluble drugs. Common fat-soluble drugs. These are drugs that build up in the body because we have more fat and they clear less quickly. They clear more slowly. Benzos, your anti-anxiety medications. Opioids, your pain medications. Statins, your anti-cholesterol medications. Beta blockers, those are used for hypertension. corticosteroids like prednisone, antipsychotics, calcium channel blockers, stimulants, including caffeine, and nicotine. Being aware that older adults may have a much slower clearance of all of these, and people with an older, cellularly older body may have a harder time clearing these drugs. Water-soluble drugs include antibiotics, ACE inhibitors, antihypertensives, diuretics, Tylenol, and lithium. The one that we work with in mental health on this list is more lithium than anything else. But a lot of people who have high levels of cellular aging are probably on antihypertensives or diuretics or Tylenol or some sort of other analgesic. As we age, kidney clearance decreases by approximately 1%, and liver clearance decreases by approximately 0.8% per year after age 40 in healthy, abstinent adults. Healthy and abstinent. If they're drinking, if they are unhealthy in some way, if they've got fatty liver disease, whatever the case is, there are a lot of things that can speed up this deterioration of the kidney and the liver. Many drugs compete for the same liver enzymes, reducing the body's ability to break down and excrete the medication. And in many other videos, I've talked about cytochrome P450. And this is a family of enzymes that break down various drugs and metabolites in the body. But when you've got multiple drugs that are being broken down by the same enzyme, that enzyme gets spread too thin. So it can't excrete. It can't break down all of the drugs as quickly as it would. It's like asking you to clean 3 rooms in a house all at once when that's just not even possible. Cytochrome P450 also declines about 16% after age 40 and up to 32% after age 70. So not only are we taking more medications that compete for these enzymes as we age, but we're also producing less of these enzymes. Our body really struggles to detoxify itself. Another cause of changes in the way the body responds to medications, including and illicit drugs, is nutrient deficiencies. Proton pump inhibitors reduce gastric acid. Oral ill health disrupts the gut microbiome. It also increases inflammation. Appetite and taste changes, as well as oral ill health, may make people not want to eat. It just doesn't taste right. Something tastes off, or it doesn't taste at all, or they have no appetite, or it hurts to eat. All of these things can impair nutrient intake in anybody, but we see it a lot more in older adults. As we age, unfortunately, our sweet and salty taste buds actually kind of go on the fritz, and it makes it more difficult. That's why a lot of older adults seem to add a lot more sugar and a lot more salt to stuff, because things just don't taste the same anymore, which has a direct impact on how much we want to eat. And stress-related gut inflammation, whether it's in our stomach or in our intestines, inhibits the absorption. Even if somebody's eating a healthy diet, if it gets into the gut and it can't be absorbed, then you're going to have nutrient deficiencies. It's just going to go out the other end. Now, why do we care so much? How does this actually impact how drugs are absorbed and used by the body? Well, nutrient deficiencies reduce albumin, which is a protein in the body that it maintains fluid balance, transports essential substances like hormones, drugs, and nutrients, and repairs tissues. If you don't have that albumin in your body, you're going to have difficulty getting the drugs to where they need to be and getting the drugs out of the system. Therefore, poor nutrient intake inhibits the creation, the production of albumin. Lack of albumin means the drugs and the toxins can't get moved throughout the body. When we don't have enough nutrients, our body can't produce the liver enzymes that it needs in order to break down the drugs. When we don't have proper nutrients coming into our body, we're going to lose muscle and or fat. Our body needs a certain amount of protein every day. If we don't get enough protein, the body will ultimately start catabolizing or turning to the muscles in our own body. If we're getting too much fat, we're going to see that go up. As our muscles go down, our base metabolism goes down and our fat goes up. So somebody who used to be able to take X dose of benzos, and that was good for them, that was a proper dose. If they've gained a lot of fat, lost a lot of muscle, and their nutrients are not where they're supposed to be, then that dose may be too high. Clinical note, patients should be encouraged to consult with their doctor or pharmacist about their medication levels if they've recently gained or lost significant weight, started taking any over-the-counter herbs, supplements, medications, including proton pump inhibitors like your acid reflux or your indigestion medications, or changed their diet. If they've started eating a high-fat diet or a no-fat diet, that is going to alter, in many cases, the types of nutrients they're getting in their body. And we want to make sure that they're getting all of the nutrients they need and their body's able to use them. In a lot of older adults, and I say older adults because these medications become more common as people age. We see a lot of older adults on statins, which are for cholesterol, beta blockers, which are for high blood pressure, and PPIs, which are for indigestion. Statins interact with alcohol, benzos, anti-anxiety medications, and opioids. Beta blockers interact with alcohol, opioids, stimulants, and cannabis. PPIs interact with cannabis, amphetamines, your stimulants, benzodiazepines, and SSRIs, your antidepressant medications, and they tend to reduce nutrient availability, going back to what we just talked about. If your patients are on statins, beta blockers, or PPIs, and they're using or prescribed one or more of these other things, make sure that they've discussed that with their doctor so their doctor can adjust their dosing as needed. Disorders that impair drug clearance alter all drug distribution or reduce the body's ability to compensate for drug effects. These are disorders that aren't necessarily drug-related. We're not talking like cirrhosis of the liver necessarily. We're talking about physical conditions that alter the body's ability to move the drugs around, to do what it needs to do to take in, absorb, and excrete the drugs. Heart failure and any sort of cardiovascular disease can reduce blood flow to the liver and gut. Well, blood needs to get to the liver in order to take the drugs there so they can be broken down. Blood needs to be taken to the gut in order to pick stuff up that's taken orally and get it out. Kidney or liver disease. These may be related to substances, may not be related to substances, or they may be related to, again, aging. Our body slows down significantly as we age. My grandfather was prescribed a particular benzodiazepine, shouldn't have been, and he was prescribed it at the level that one would prescribe for a 40-year-old. Well, he was in his 70s. It didn't turn out well. He ended up in the hospital on the verge of a coma, and they had to do whatever doctors do to bring him out of that. Frailty. This is something we see a lot in older adults, but it's also something we see a lot in people who are longtime substance abusers. they lose a lot of muscle. They may or may not have fat. They may be on the verge of underweight, or they may be very underweight. People who are frail have reduced homeostatic reserve. This means the body just can't compensate for drug effects like reduced heart rate or reduced blood pressure. When somebody takes a drug like an opioid or a benzo that slows the nervous system down, the body can't compensate. When they stand up, they're going to get dizzier. They're going to have a higher risk of falls. And it can't try to maintain that homeostasis and keep the heart rate going at the rate it needs to, for example. Cognitive impairment. This doesn't impact the way the drug moves through the body, but as people are stressed, as people lose white matter, as people age, they automatically start to have some level of cognitive slowing. As we age, cellularly, we start to see cognitive slowing. We may see in people with cognitive slowing drug noncompliance. A lot of times this isn't intentional. They may forget to take their medications. It's like, well, did I take it or not? Some people, if they can't remember whether they took it or not, will skip the dose. Other people will go ahead and take another dose because they're like, well, if I didn't take it, then I'll take it now. So you can see people becoming very deficient or very excessive in the blood levels of their medications if they are not able to remember when they've taken it. Now, there are devices you can get now that I think will portion out up to like 16 medications or something. If you have an older adult who takes a lot of meds, that might be worth looking into. You can also have them order the meds from an online pharmacy that packages them up in daily packets that have the date on them. So they can look and they can see, do I have the February 1st dose here? If I do, I need to take it. If I can't find it, must have taken it already. Another issue that we see in aging bodies is vision issues. And I know for myself, I'm trying to read on bottles now. How many capsules of this am I supposed to take? Well, it looks like 3. And then I put my glasses on and it's 2. So it is important to make sure that people have the ability to visually read what is on their prescription bottle. If they can't read what comes off of the pharmacy, then they need to write it down on a piece of paper or put a piece of masking tape on their bottle and use a magic marker to write how many pills they're supposed to have, how often. That helps a lot of people maintain their independence and their safety. Other brain changes bodily changes in the aging body. Increased blood-brain barrier permeability. We know that blood-brain barrier permeability increases as stress increases. We know that the aging body and the aging nervous system tend to become what we call sympathetic dominant. So the aging person often has a higher level of chronic stress and a higher level of underlying systemic inflammation than the younger individual. All of these things contribute to increased blood-brain barrier permeability, which means that drugs, as well as toxins, can get into the brain a lot easier, which stimulates the brain's immune system, which increases neuroinflammation, and you've got a whole bunch of other problems after that. We also see reduced white matter. Part of this is due to that increased blood-brain barrier permeability. When people have reduced white matter, those are specific types of cells in the brain. They show memory problems, slowed cognitive processing, executive dysfunction, difficulty with planning, organizing, problem solving, sustained attention deficits, reduced insight into their own cognitive changes. They're not able to recognize that they're not making good decisions. They're not able to recognize that their thinking doesn't seem to make a lot of sense. They may experience depression, apathy, irritability, mood swings, or balance and gait difficulties. And there are some other symptoms, but these are the big ones. Now, I want you to look at this list we have. How many of these symptoms of reduced white matter may be misdiagnosed for depression, for anxiety, for dementia in people? Now, we do see an overlap in dementia with reduced white matter. However, we need to understand that as the brain loses white matter, as we age, we tend to lose white matter as a result of systemic inflammation, etc. We may see some of these things. What can we do? As clinicians, as non-prescribers, we can help people rebalance their autonomic nervous system, strengthen that vagus nerve, that parasympathetic nervous system, that ability to downregulate, increase their mindfulness in order to be more aware of when they're starting to feel distressed or stressed so they can downregulate, recognizing, and I just kind of put it a little oversimplified to my clients, but I say for every minute that you're stressed, you're increasing the amount of damage in your brain because you're increasing inflammation. Being aware of that, people become more cognizant. Now, the brain and the body is really good at responding, adapting, and healing from acute stress. It's that ongoing chronic stress, that ongoing slow burn that tends to increase inflammation that we don't even recognize. We can help people rebalance. We can help people educate themselves about anti-inflammatory diets that are high in probiotics, fermented foods, prebiotics, fibers, antioxidants, colorful fruits and vegetables, in order to try to reduce some of that inflammation in their body and give their body what it needs in order to function appropriately. Encourage them to talk with a registered dietitian. Make sure they're going to the dentist. If they're having any sort of oral health issues, their dentures don't fit right, their tooth hurts, they've got bleeding gums, any of that can be problematic. You start having bleeding gums, think about how close your gums are to your brain. Think about how quickly bacteria from your mouth can get into openings in your gums. Bleeding gums and oral health are very important for reducing systemic inflammation and helping the body do everything it can to maintain health and vitality and white matter, quite honestly. Provide supportive solutions for things that already exist. If they're having some memory problems or cognitive slowing, help them identify ways to support themselves, whether that's writing down things, push notifications, having somebody call and remind them. All of those things can be helpful. Destigmatize. Obviously, we want to screen for any signs of dementia, especially if it's kind of rapidly onset, or it seems to be significantly different than other people of their age. If you think a person may be starting to develop some level of dementia, regardless of their age, their chronological age, refer to their doctor for a screening. It's not for us to say, oh, it's just stress or oh, it's just depression. If you think there's a problem, refer. There is a lot that can be done to slow the progression of dementia and brain deterioration if it's caught early. However, we also want for people who are showing mild symptoms of cognitive slowing, especially if it is stress, depression, anxiety, grief related, or they suddenly started not getting enough sleep, we want to help them recognize that everybody's cognition slows some as they age. That doesn't mean you're developing dementia. It means your body's aging. It means your brain's aging. So let's see what we can do to help you live your highest quality of life and have some cognitive slowing. Because if the person stays stressed about that cognitive slowing, they're increasing that systemic inflammation. They're going to increase that white matter damage. I want you to also think about these issues in terms of increasing somebody's susceptibility to addictive behaviors or addictions. Addictions tend to, at least temporarily, make somebody feel better. It helps them reduce stress. What have we just said? Well, a lot of people who are older, a lot of people who are physiologically older, tend to have a lot of chronic stress, and they may be desperately seeking stress reduction. The substance or behavior may do that briefly, but ultimately the rebound from that adds a whole lot more stress to the symptom. Their slowed cognitive processing speed. They may not think it through all the way about, is this really the best choice? Their difficulty with planning, organizing, and problem solving. It may be difficult for them to, for example, if we take gambling, a lot of older adults have a huge problem with gambling, especially when it comes to bingo and lottery and some other things that people normalize. Well, gambling is gambling is gambling. And many older adults, and that a lot of older adults are very attracted to slot machines. If you live in a place where there's a casino that has slot machines, that can be a high-risk environment. They may not be able to think, well, I've got this much money, and then once I've paid all my bills, I have this much left over that I can gamble with. They may see their account and they say, well, I have this much money. But because they're having difficulty with planning, organizing, and problem solving, they're not thinking ahead to what else do I need to use it for. Sustained attention deficits and reduced insight, both of those tend to make people more susceptible to being impulsive, to seeking out something that's going to make them feel better in the moment without playing the tape through, without thinking about how am I going to feel tomorrow? What consequences is this going to have for me tomorrow, a week from now, a month from now? People with depression, apathy, irritability, dysregulation, they want to feel better. And a lot of older adults tend to gravitate toward alcohol and other activities that make them feel better. Yes, there is social use, there is recreational use. I'm not saying everybody has to be abstinent, but it's important to recognize when that use, whatever it is, gambling, drugs, alcohol, etc. It's important to recognize when that use is starting to cause clinically significant problems in one or more areas of life. And one of those areas of life is their health. Causes of reduced white matter integrity, and I kind of hinted about this earlier. Long-term use of alcohol. They found that even one drink per day or long-term use of other substances contributes to reduced white matter. It increases stress, it increases the neurotoxicity, it increases inflammation in the brain, which decreases white matter. Chronic stress dysregulates the stress response, the HPA axis, increases glucocorticoids like cortisol. It also increases glutamate, reduces the growth factors, BDNF, which is one of the chemicals in your brain that helps your brain repair itself. So not only are we increasing damage, we're reducing its ability to heal itself. It decreases dendritic branching, so those neurons aren't branching, they're just getting pruned off. They're not able to reach out and connect with other neurons. And it impairs myelination. Chronic stress impairs the body's ability to myelinate or insulate the nerves to help the signals get from one place to another. Think about it like a stripped wire that doesn't have insulation on it. It's not nearly as conductive. And chronic inflammation. Long-term use of alcohol or substances and chronic stress lead to chronic inflammation. But there are a lot of other issues, whether it's dietary or genetic or physiological, that can cause chronic inflammation. Our job as counselors and social workers is to help people identify what sources of stress in any of the pieces of life, physical, interpersonal, emotional, cognitive, environmental, what sources of stress in any of those areas or pieces of your life can be eliminated. Which ones can we just get rid of and say, you know what, not going to stress about this anymore, or here's a fix that we can do to make this less stressful. And what can we mitigate? Because stress is stress. It's going to happen. When stress happens or when there's unavoidable stress, how can we mitigate it so it causes distress in the person? I'm not saying it's not going to, but it's not overwhelming. It's not never ending. It is acute, episodic, and manageable. Gambling and impulsivity severity negatively correlated with white matter integrity. That means as white matter integrity goes up, as the brain retains white matter, gambling and impulsivity go down. As gambling and impulsivity go up, we see that white matter is decreased. Another clinical note, benzodiazepines are generally avoided in adults 65 and older. And this is another one of those notes. If your client tells you that, hey, I use some of my kids' benzos, we want to make sure they know that that's, probably not a smart move. However, there are still doctors out there who are treating older adults or adults with older physiology that are physiologically aged and prescribing medications that the older body cannot clear as effectively. If the person is taking benzos and they are feeling excessively sedated, drowsy, dizzy, any sort of problematic symptom that started right when they started taking those benzos, or 2 or 3, 4 days afterwards, it's important, it's vital that they reach out to their physician immediately. Another one that's avoided is opioids in older adults, unless safer alternatives are not available. In palliative care, obviously, we see a lot of opioid use, but in people who are not in palliative care, doctors tend to avoid anything that's going to slow the body down, your benzos, your barbiturates, your opioids, because the older aging body doesn't have the homeostatic reserve to bounce back from the respiratory depression, from the heart rate slowing, etc. And the body just can't clear it nearly as effectively. Plus, these drugs, opioids and benzos and barbiturates, interact with most of the common medications that a lot of older adults are on. We move on to diagnosis. Is it addiction or is it aging? Sometimes it's hard to tell. Symptoms of substance use disorders can mimic normal aging or other chronic conditions. We don't want to pathologize somebody who is having emotional lability, who seems to be forgetful, who seems to be having difficulty with balance, slurring their words maybe, and assume that is a substance use disorder. Even if they're in substance use disorder treatment, we don't want to accuse them of relapsing without having data to back it up, because there are a lot of symptoms with aging and with some of the medications they may be prescribed with difficulty regulating blood sugar that may appear as if the person is intoxicated or withdrawing. Standard DSM-5 criteria for substance use disorders may fail to detect problematic use in older adults. Some of the things that we look at in those criteria, remember, you don't have to have all of them, you just have to have some of the criteria. But older adults are not, a lot of them that we're working with, are not going to work regularly anymore. They're retired, and they may not have a lot of things that they want to do every day. The criteria of, is substance use reducing their engagement in activities of importance, they may say no. I don't have anything that's really important to do anymore. That's a clinical issue. We can help them identify activities to help them find meaning. But social isolation. A lot of older adults are not going to experience relationship difficulties because of their use, because they're living alone, because they are somewhat isolated, and a lot of people may not even realize that they're drinking or using. When I say reduced areas of functioning, again, this kind of goes back up to reduced activities of importance, but they're not doing as many things. They're not having to go get their groceries. They can have them delivered now. They're not having to go to work and function anymore. They're retired. They're not having to fill in the blank. There's a lot of things that older adults don't have to be responsible for that they were responsible for as a younger adult, which makes it even more difficult to identify, is this person having problems as a result of use? What's changed? Well, and there are reduced opportunities for a lot of older adults to engage in physically dangerous operation of machinery or situations under use. Again, as a younger person, driving is one of the big issues that we see. And if somebody's driving under the influence, that is a situation that's physically dangerous, not a smart move, and it meets the criteria. An older adult may have found a way not to drive. They don't have to drive. They don't have to operate heavy machinery. Finding issues with this for an older adult, it may not mean that they're not having issues with substance use. It may mean that they don't engage in physically dangerous situations anymore. The only caveat here, kind of, sort of, might be if the substance they're using is making them more prone to falls. And in that case, then using when they're alone could be considered a physically dangerous situation. Other markers that we look at with diagnosing addiction that may exist for older adults or adults with aging bodies. Spending more time thinking about using or recovering from use than intended. Even behavioral addictions, because they flood the system with neurotransmitters, and then those neurotransmitters recede so quickly, it's exhausting on the body. And using substances themselves definitely take longer to get out of the body. The recovery period takes longer. And then obviously thinking about wanting to use, figuring out how you're going to use, figuring out when you're going to use, and then using taking longer than intended. That's common across age groups. Inability to cut down or quit, common across age groups. A lot of older adults that we talk to, or that I've talked to over the past couple of decades, may not have a desire to cut down or quit unless there's some external force saying, you've got to cut down on this, or we're going to put you in assisted living. You've got to cut down on this, or you're going to go back to jail. But if there's not an external force that can be enforced, there are a lot of older adults who don't see the need. They're like, well, I don't have to work anymore. I don't have to drive anymore. I don't have to do this anymore. So what's the big deal? We can help them identify what's important in their rich and meaningful life and explore how their current behaviors may be supporting or undermining that. Tolerance. Now, this is a weird one with older adults because they don't clear the drug as quickly and because they may be more reactive to the substance. They don't seem to develop tolerance, but everything going on under the hood says they are. Instead of needing more substance, they may need less of it, but it's because their body is much more reactive for some reason. Identifying tolerance in an older adult or in someone who has a significantly cellularly aged body may be more difficult because of that. Withdrawal symptoms. in older adults. Maybe more severe or more subtle and protracted because the drug leaves the body more slowly. Depending on what we're talking about, depending on the drug, depending on the person. That's not a slam dunk either for diagnosing addiction in someone who is older. Now remember, addiction causes two or more problems over 6 months in one or more areas of life for a person. The drug, the behavior itself causes problems for the person. And we don't want to get too hung up on necessarily identifying all of these criteria, because you don't need that to identify substance misuse or pathological gambling. As a counselor, social worker, or even a caregiver, because I know some people watching are caregivers, it's just as important to correctly identify possible substance misuse as it is to identify possible undiagnosed or uncontrolled disease states and refer the person to their primary care provider for diagnosis. If they are having difficulty with slurring their words, with memory, with emotional outbursts, with their gait, with their balance, referring to the PCP, the primary care physician, can be a good step to rule out anything neurological that's going on under the hood. We don't want to miss something. They can have both things occurring at the same time. They can have neurological and they can have addictive issues going on, or it could be one or the other. We don't want to turn a blind eye. We don't want to assume that somebody with a lifelong history of alcohol use, not misuse, but alcohol use, is slowing down cognitively simply because of their alcohol use. There could be other things going on. When we talk about withdrawal, remember I said it can be really difficult to identify tolerance and withdrawal in the older body. We need to ensure that what we're seeing isn't a side effect from other drugs, drug-drug interactions, aging, current mental or physical illness like an inner ear infection or a UTI, which can cause symptoms of delirium, anxiety, depression, or arthritis or diabetes. Confusion happens for a lot of people when they don't feel well, when there's something going on in the body. Increased resting pulse rate can happen when people are in pain. It's not necessarily that they're taking stimulants. Gastrointestinal upset. Well, that can happen when you get upset. It can happen when you drink alcohol. It can happen for a lot of reasons. Sweating is very common in people who have various cardiovascular diseases. Tremor can be caused by other medications, Parkinson's disease. Yawning and fatigue. Now, this is one of those symptoms that we look at on the opioid withdrawal scale. But you know what? There's a lot of people that yawn and get fatigued as they get older. They yawn a lot more. When we yawn, it's our body saying, hey, I'm not getting enough oxygen. And fatigue happens when we're nutrient deficient, when we're not getting enough oxygen, or when we're just plumb tired. Anxiety, irritability, and restlessness being revved up is a sign of sympathetic dominance, which is common in aging. Is this more anxiety, irritability, and restlessness than we usually see in this person? And if so, what's the cause? We don't want to assume that they're withdrawing or intoxicated. Bone and joint aches, very common in people who are withdrawing from opioids, but it's also very common in people as we age. We develop arthritis, we hurt. Goose flesh skin, goosebumps is what we called it when I was growing up. A lot of people who are older have difficulty regulating their temperature, so they may get goosebumps. They may be cold a lot. We want to check that, differentially diagnose what might be causing it. And with differential diagnosis, it always comes back to what is the symptom? When did it start? Did anything change right before it started? Did you start taking a new medication? Did you alter the thermostat in your house? Did anything change? And is this symptom typical for this person, or is it atypical, and is it significant? A resting pulse rate of mine's 53. If my resting pulse rate is at 56, it's non-significant. It means I worked out yesterday and my body's still recovering. If my resting heart rate is in the mid or upper 70s, that indicates that there might be a problem somewhere, but it could be that I'm fighting off an illness that I don't even know I have yet. And runny nose or tearing can be caused by beta blockers. These are, and ACE inhibitors. These are antihypertensive medications. If the person just started taking that medication, just increased or decreased their dosage, that could be it. Runny nose and tearing can also be caused by hay fever or a variety of other things. Jumping to the assumption that signs of withdrawal for this substance are these 6 things, and you have all of these 6 things, that doesn't necessarily mean the person is in withdrawal. It could be something completely different. Verifying with blood tests is really important. Your CLIA-waived on-site drug cups are very difficult to interpret when you've got somebody that is taking a lot of different medications. Medical conditions that overlap substance use, aging, dementia, and cardiovascular conditions can all cause cognitive slowing and confusion and even irritability and delirium. Liver disease can cause fatigue, appetite changes, confusion, and weight loss. Diabetes, especially those with advanced diabetes that have peripheral neuropathy or numbness in their fingers and their toes, and sometimes even starting to lose their hearing, may have a lot of issues with falls and poor balance. Some of our balance is regulated by our inner ear, and people with diabetes and peripheral neuropathy often have impairments in the nerves in their inner ear, which actually impair their balance. And age-related sympathetic dominance can cause irritability and insomnia. In terms of age-appropriate screening instruments for older adults, there's the SMAST-G, the Short Michigan Alcoholism Screening Test geriatric version, and the SAMI, or Senior Alcohol Misuse Indicator. Now, what do we notice? Both of these are for alcohol. There are no normed screening tools for opioid stimulant or cannabis misuse in older adults, which really sucks because that means we don't have tools that can help us with differential diagnosis. And as I mentioned, CLIA-waived on-site tests are more difficult to interpret due to the presence of multiple disease states, different physiological stuff going on, and different medications. There are a lot of medications that older adults take that can give a false positive or a false negative on those on-site tests. Older adults really need to have urine screenings sent off to the lab to go through a mass spectrometer. CLIA-waived on-site tests. For any of you who are addiction counselors, there's a higher risk of false positives because older adults often take multiple medications that are called cross-reactors. This triggers a positive result for a drug the person never took. There are different detection windows. As people age, drugs leave the body more slowly. Somebody may say, I have been clean for a week, and you test them and they're still testing dirty. Well, they may still have been clean for a week, but if their body couldn't excrete the substance quick enough, it may still have been high enough to trigger that test. Sending it off to the lab to get an actual number so you can see the drug decreasing in the person's system is the only ethical way to monitor that. And on-site cups used fixed cutoff levels to determine a positive or negative. Because older adults have more dilute urine, or metabolize drugs differently. They may have drugs in their system that fall just below these cutoffs, leading to a false negative. And yeah, I know I said that people tend to have less water in their body, but I'm saying their urine is more dilute. It's true. It's counterintuitive, but the kidneys, as they start to decline, have more difficulty concentrating the urine. So you actually do get less dilute urine, even if the body levels of water are lower than they were before. Families and individuals may not recognize that long-standing, non-clinical patterns of use may become harmful with aging due to physiological changes and or medication interactions. Somebody who regularly drank alcohol all their life may start having more difficulty if they're suddenly prescribed other medications that start interacting with the alcohol and making it harder for the body to excrete it or making it more potent, etc. Alcohol anxiety, that anxiety that people feel as alcohol leaves the body, is often intensified in older adults, increasing their desire to either drink again or find something else to take the edge off. Alcohol may intensify the side effects of antihistamines and other drugs, especially depressant drugs. So important to recognize that when depressants get into the system together, it's not a 1 + 1 = 2. It's a 1 + 1 = 5, even for the normal body. And since the older adult has less homeostatic reserve, that can be really problematic. And benzodiazepine and opioid levels that were once safe may rapidly become toxic because the body is slower to excrete them. There are a lot of older adults who got a prescription for benzos or opioids, 3-4 years ago. Maybe they went to the dentist and had dental work done and they still have opioids left from then. And then they hurt themselves and they try to self-medicate now. Well, 4 years can be a big difference when we talk about how quickly the body can excrete medications and especially when we start looking at what is your body composition compared to what it was back then. Clinical medical practice guidelines currently focus on the treatment of individual disorders and are often not applicable to people with multiple disorders. According to a 2005 study following all of the individual clinical guidelines applicable to a hypothetical 70-year-old woman with COPD, type 2 diabetes, osteoporosis, hypertension, and osteoarthritis, would result in her taking a list of medications that would put her at significant risk of multiple drug side effects and drug-drug interactions. Just because the patient says, well, my doctor prescribed this, doesn't necessarily mean it's not causing them a problem. You can go to drugs.com, drug interactions checker, and look for drug interactions. They also may be more forthcoming with you about other supplements and things that they're taking, which could also be impacting the effect of different medications. Challenges with treatment for older adults. Cognitive slowing requires modified group treatment. Generally, you want to have people who are at the same cognitive speed in the same groups in order to keep everybody engaged at the same rate. Reduced social support because they're not going to work anymore. They may not live in a community where there's a lot of other people around during the day. They may have transportation issues, which makes getting to treatment more difficult, as well as getting to other activities. Leaving the house may become more difficult. Yes, there are Ubers, but Ubers are expensive. If they're on a fixed income, that's not going to work. There's shame and stigma for reaching out, even in this day and age, for reaching out for help with treatment for mental health or addiction issues. As I mentioned earlier, many older adults just lack a desire to stop. They're like, how's it hurting now? I don't have to go to work. I don't have to do this. So what's the big deal? And the co-occurring medical and psychiatric disorders often cause a complex presentation because they feed on each other. Reduced liver and kidney function, altered body composition, and nutrient deficiencies increase susceptibility to prescribed as well as illicit drug effects and side effects. Substance use disorders often mimic normal aging or chronic conditions and must be carefully differentially diagnosed. Drug side effects and interactions are significant concerns due to the frequent use of statins, beta blockers, and PPIs in this population. Safe doses, what was once a safe dose of benzodiazepines and opioids, can rapidly become toxic due to reduced clearance. And white matter changes in the brain cause changes in each piece of life, increasing vulnerability to addictive behaviors. As counselors, we must screen for both substance misuse and possible undiagnosed medical conditions and encourage clients to consult their primary care about medication levels when experiencing weight changes, dietary changes, or starting any new medication or over-the-counter supplement.